would a person have ventricular tachycardia? A person will have ventricular tachycardia because of an MI, so myocardial ischemia, coronary artery disease with prior MIs, valvular heart disease, heart failure, cardiomyopathy, electrical imbalance like hypokalemia. And what are we going to see when we talk about assessing the patient? What are their signs and symptoms? What will they look like if they're having signs and symptoms? They'll be lightheaded, they'll be dizzy, they'll have palpitations, fatigue, chest pain, right? A lot of the things that they'll have if they have an MI, okay? Now, when we talk about treatment, we said check first to see if they have a pulse or no pulse. So if they are stable, no signs and symptoms of decreased cardiac output, right? We're going to check pulse. If person is stable with a pulse, we're going to give amiodarone and cardiovert them. If they're unstable with a pulse, then we're going to cardiovert them. If they're unstable with no pulse, we're going to treat them as VFib. And that's with defibrillation. So with chronic VTAC, oral, we're going to give them oral antiemetics, implantable cardiovert defibrillator, and ablation. So as you remember, the ablation is when they go in and they burn that area, that ectopic area that's sending extra signals. Okay, so again, stable with no signs of decreased cardiac output. We're always checking the pulse. When we check the pulse, if they have a pulse and they're stable, we're giving amiodarone and cardioversion. If they're unstable and have a pulse, we're doing cardioversion. If they're unstable, still checking the pulse. If there's no pulse, we're treating them as VFib. What is VFib? This is VFib. So you can see how this is different from here, right? We mentioned how if we put a line through here, it's not going to hit every line. There's like too much happening that's not even, not equal. So that's how you can identify VFib. Same here. Put a line across here. The line's not going to hit each curve. So that tells you it's VFib. The heart is quivering. It's not pumping properly. Obviously, we said neither one is good. VTAC is not good. VFib is not good. But VFib, as you can tell, is much worse. Okay, so commonly referred to as VFib, it is a chronic pattern of electrical activity in the ventricles where the electrical impulse comes from many different foci and produces non-effective muscle activity. When untreated, it can cause cardiac death. So you can imagine how this can just quickly turn into a straight line. How this can eventually turn into this and then a straight line. So the difference between here and here, remember in one of our classes, I talked about a person can have coarse or fine. And so this is the fine and this is the coarse. Do you remember what I said the difference were between the coarse and the fine? Not exactly the strength of contractions, but yes, it is the strength of a contraction.
The angle that you're viewing it from?
Not the angle. So let's say it's the strength of contraction. What's the difference between the strength of this one and the strength of that one? Which one is stronger?
The lower one.
The lower one. What would possibly cause this to be less strength?
Or conduction.
The timing. The longer they stay in VFib, the finer it gets, right? So they've been in VFib so long that the contraction, the strength of contraction, yes, has become weaker. And so now it looks like this, and eventually it's just tired and it just stops. Okay, so it's not just about the strength, it's about the time. Okay, so when we think about ventricular fibrillation, we're looking at rhythm, there's none. Rate, unable to determine. P wave, not identifiable. PR, not measurable. QR, S, bizarre, varying shapes and directions. Okay, What are we going to treat them with? We're accessing the patient. We are defibrillating, right? Defibrillating because they got to get out of this thing fast, right? The heart can't beat that long in that rhythm for too long, because eventually it'll just stop. So what are some causes? Most common cause, this is the most common cause of death in MI patients. So we have hypoxia can cause it, cardiomyopathy, electrolyte imbalance, digitalis toxicity. Do you guys study digitalis yet? Not yet, okay. Well, when you do, one of the big problems is it has to have a threshold. And so you have to constantly measure their threshold to see how much it is. And if it's too much, they'll have the toxicity. One of the huge signs is like a green halo, right? So when you study that, you'll know a little bit more about the toxicity. So do you remember any other drugs that you have to check the threshold for, other than now that I said the digitalis? So it'll be, what is it called? Seizure meds. Have you guys done seizures yet? Not yet. Okay, so seizure meds, psych meds, you haven't done psych yet. But there are certain drugs that they have to take the measurement, and you will know by the threshold level if it's high or if it's low. Usually if it's too low, the person's going to revert back into whatever symptoms they had prior to the medication. And if it's too high, they're going to build some kind of toxicity which can injure something. Maybe give them tinnitus, maybe do something, okay? All right, so we already mentioned the treatment, okay? Course or fine, we just talked about that. So if there is no pulse and patient is conscious, there is no fibrillation. If there is no pulse, then we do CPR. So if there's no pulse, if there is a pulse and the patient is conscious, there is no VFib. But if there is no pulse, then we're going to do CPR, whether it's unwitnessed, and we're going to defibrillate and start ACLS protocols. Then we get to asystole and PEA. So asystole is just a line or a P. This person is, the biggest possibility is there for them to die, right? This is called a ventricular standstill. The patient is completely unresponsive. There's no electrical activity in the heart and no cardiac output. So they're relatively gone, right? I always see, like in the movies, they show you a flat line and then they bring them back. That is like, oh my goodness, so rare. Miracles do happen, right? So apparently they happen all the time in the movies. But in real life, they don't come back from this. And the reason why is you don't have the conduction, right? There's nothing for the signal to land on to initiate a contraction, okay? So there's no activity here. Where are you putting the joules, the electricity to start, right? And here, this is not enough, right? It might, if this happens, there could be a potential possibility, but right here, most definitely not. But the thing about this, however, is we can't just say person's dead if we see this, right? If we come upon this, we have to do CPR, we have to do medications, whatever we need to do in order to get them out of this. And then after all the interventions, we say, okay, person has passed, but you want to be able to initiate some kind of plan, okay? Especially as a nurse, it's not our position to call any person deceased or to call it, you know, it's the doctor's role. So what do we do? What do we know? The characteristics, it's a flat line or P waves only, no ventricular rate rhythm. What is our treatment? We assess the patient, we give them atropine or CPR, not a shockable rhythm. So the defibrillator is going to just scan and scan and scan and scan, and it's not going to find anywhere to shock. Okay, so flat line on strip, no electrical activity, pacemaker spikes may be noted. So if the person, we were going to talk about pacemaker in a little while, if the person has a pacemaker, the pacemaker might be sending signals, right? but the heart is not receiving them. It's not capturing them to produce any reaction. Okay? The cause, extensive myocardial damage, MI, hypoxia, increase or decrease potassium level, hypothermia, drug overdose, electrical shock, pulmonary emboli. How do we treat it? CPR and epinephrine, Q 3 to 5 minutes, determine underlying cause and treat. There's poor prognosis, right? So is it impossible? No, but it's rare. And it's because there's that possibility that we keep trying. More on pulsus activities. So we have the characteristics we already mentioned. So we have the clinical situation, right? So the pulsus activities mean that your heart still has electrical activity, but it isn't strong or organized enough to make your heart pump. On an electrical cardiogram, the PEA forms wave patterns, some which look very similar to normal heart rhythms. That means your heart's electrical signal is still working. So if that happens, then you have more of a chance, but it is too weak or disorganized and you don't have a pulse with it. With asystole, you have no pulse, no electrical activity, right? So once you have asystole, can't do anything. PEA, you have a slight chance. There's a little something there. We might be able to hop on and get some activity going, but with the asystole, nothing. There's nothing. So with the pulses, it's not a shockable rhythm. We treat as asystole. So asystole and identify and reverse underlying cause if we can. Okay, let's talk about pace rhythms. Here are pace rhythms. So I had mentioned this in the previous class to give you a little preview. So we talked about if the line is here in front of the P, this is called this is called A pace, atrial. It's pacing the atrium. And if the line, which is called the spike, is before the ventricle, is called V pace. And what if it is in front of the A and the V? What is it called? AV pace, yes. Okay? So what's happening here is the heart doesn't know to beat on its own. So what is not working? The SA node, right? The SA node is our initiator. It tells the heart when to beat, how quickly to beat, right? But if it's not working, the heart's not going to beat. And so it needs a little help. And so we want to get a pacemaker. We put the pacemaker there. It sends a signal. It sends the spike. The spike says, time to beat. The heart can capture it, receive it, recognize it, and then produce a signal. This is the signal, right? It does the P, Q, or ST. Now, if there's a problem with the atrium and the ventricle, then we might need to put the AV pace. If there's a problem with just the ventricle, we do the V pace. But the point is, spikes mean signal was sent. Action happens if we see the PQ or ST. We can have a signal to initiate contraction and no action. That can happen. Here's what it looks like on the strip. So here we have, this one is what? AV pace. Yep, AV pace. So this one didn't even need it because the heart beat on its own. The heart wasn't beating here. It did send the signal. The atrium caught it, but the ventricles did not. So then they had to do it again, and it worked. And it continued and stopped again, right? So the heart is able to identify when it's getting a signal from its own system and when the pacemaker is able to identify when it needs to help the heart beat, right? So here's the care of a patient with a pacemaker. We're going to monitor them, right? So we're looking at the pace spike presented before the P and or before Q or S. Only before P means A pace. Only before Q or S means V pace. Before both, AV pace. Okay, we're gonna, the treatment pacemaker setting may need adjustment if failed to capture. That's if we see the spike, but nothing happens at the end. And we can replace if batteries are failing. We also tell them, not to lift heavy objects, how much to lift when they start feeling better, right? What else? So we monitor, reposition as needed with external temporary pacemaker, check vital signs, assess for decreased cardiac output. How would we know we have decreased cardiac output? Sure, but how would we as the nurse assess that?
Oh.
Labs would tell us, sure. What else? How would we see that if we're assessing the patient? Perfusion. So how do we check for perfusion? Blood pressure, capillary fill. Pulses. Yes. Okay. So now this is AV block. We're not covering that in our class. This is just a nice to know concept, knowing that it exists. That's quarter 4 mostly. So you do not have to study this for your exam. But we also have AV block. We have first degree, second degree, 1, second degree 2, and third degree. And what it just means is there's a disconnection between the atrium and the ventricles. They don't communicate with each other. Kind of like why we see the pacemaker was needed, right? Atrium did something, ventricle did nothing. Ventricle did something, and even though the atrium didn't do anything, like it's disconnected. So we need a pacemaker there to set them aright, right? Tell them when to beat, how to beat, because they're not talking to each other. They're mad at each other for some reason, right? Okay, let's do some questions. Do you have questions in your slides so I can see whether I'm giving points for this or not? No. Great. So let's get some points, shall we? I've been behind, so I haven't uploaded the 3 points. 2 times that you had gained points, but let's do some exercise for some points. Do you want to work in groups or do you want to work individually? You want to gain points in groups? All right. All right. So the different groups. Here we go. The nurse is watching the cardiac monitor. Ooh, I got to turn this off because this is going to be in our next class next